you can be that role model, that voice that promotes change. You can be a motivator for change that can then bubble up as a role model for other people to adopt your positive change.
Inclusive education isn't just a goal, it's a responsibility. In this episode, we explore how critical thinking, compassion, and equity can transform nursing education for every student. Welcome to the Lippincott Spark, Illuminating Nursing Education podcast. I'm Dr. Kelly Drees. Join us as we ignite your passion for nursing education and leadership. We'll explore the latest trends, hear from expert nurses, and provide tools to keep you inspired. Let's dive into today's episode and continue your professional development journey together. Only 28% of nursing programs track students' experience, yet every student's journey matters. What happens when we start listening to those journeys? In this episode of Lippincott Spark, we explore how social determinants of learning, like social economic status, family responsibilities, and educational background, shape nursing student success. Our guest, Dr. Cheryl W. Thompson, is a nurse educator, author, and advocate with over 30 years of experience. Her latest research, accepted by the Journal of Professional Nursing, dives deep into how these factors influence outcomes and how institutions can respond with equity and empathy. Together, we'll uncover how institutions can move beyond one-size-fits-all approaches and foster cultures of support and critical thinking so every student feels seen, supported, and prepared to thrive. Welcome, Cheryl.
Thank you. I'm happy to be here.
Let's begin by confronting a fundamental truth in nursing education. Despite decades of well-intended diversity efforts, our nursing workforce still really doesn't reflect the rich diversity of the communities we serve. One of the most persistent and often overlooked barriers is the outsized emphasis placed on first-time NCLEX pass rates. So let's dig into the hard questions. Cheryl, how does the emphasis on NCLEX first-time pass rates create barriers for underrepresented students? What does that look like in practice?
Thank you, Kelly. And that is one of the main underpinnings of my work and my writing, that we're in this situation because we have NCLEX as a gatekeeping mechanism that disproportionately affects certain groups of students. And the ripple effect is huge. The first-time pass rate, as many educators are very familiar, it's a sole program quality indicator. And it creates for us what I like to call a wicked problem, because there's just no simple solution. It's not going to go away. First-time pass rates, the NCLEX is a valid and reliable measure for entry-level practice competency from a knowledge standpoint. And, we have to have some sort of gateway to our professional practice. So a solution of getting rid of it is not an option. We don't have disaggregated demographic data the way some other professional practices have that tell us about the characteristics of individuals who are not successful on their first or even second, third try with NCLEX. But we do have some indirect data, and we know that students from underrepresented minority groups are less likely to be admitted to nursing programs, to progress through, and they're less likely to graduate. And that just kind of perpetuates the problem, Kelly, that you noted in the beginning, that we don't have a nursing workforce that looks like the population we serve. We've made progress, but we still have a lot of work to do. We also know from some secondary data that programs who have higher proportions of underrepresented minority students tend to have lower pass rates or address strategies to improve pass rates with additional support for students, but that need to be able to be successful on a standardized test at the end of the program, that drives all of our admission and progressive policies. So we have to have our students perform on standardized testing and on exam averages. And, that just really impacts underrepresented minority students in a whole lot of ways.
That's a powerful insight. And I'd love to explore how we can shift our perspective. I agree that nursing education can really learn from healthcare's transformation around social determinants of health, right? Some educators may feel overwhelmed by the idea of systemic change. What are some realistic, scalable interventions that can be implemented with existing resources? Shell, can you give us some examples of that?
There are a few that are actionable. I mean, there's a whole list of interventions, but in picking, the most important ones that I see as most important, I think the first foundation is creating a culture of inclusivity. And that means that, we really want to have a framework where our students feel valued, heard, and supported. And we really, paralleling what healthcare did with this switch from fee for service to value based care. We went from doing things to patients to working with patients to helping them on their journey to better health outcomes. That's kind of the same shift that we can do in nursing education. So that instead of looking at our language that's often punitive, right? We have in our handbooks and our syllabi, if you do this, you'll be dismissed from the program. 2 clinical failures, you're dismissed from the program. Or exam average, repeating courses. And that sets a us versus them mentality for all of our students and puts the students on the defensive. So that's just one scalable intervention that we can look at our language and our messaging to create this culture of inclusivity that we are here, we exist to support you on your journey, and we are going to work with you to support your success. And we're going to look at you as an individual, and we're going to help tailor what we can provide for you to be successful. Some of the things are so easy, just like learning students' names with the correct pronunciation, making a commitment to that, identifying microaggressions and looking at our own behavior. Sometimes we can even have a peer come in and observe us. Microaggressions can be nonverbal. We don't even realize that we all carry implicit bias. There are unlimited opportunities to learn how to improve. Just like, our students are on a journey of learning, we are as well. And we can adopt this growth mindset of how can we learn and do better.
We often teach our students to ask why when a patient isn't responding as expected. Just as we teach students to ask why in the clinical setting, I'm thinking we can apply that same lens to educating nursing students. So, how can we shift from blaming the students to examining institutional barriers in nursing education?
That's a great question. You and I were both in healthcare when the care was in the old way, before we really looked at social determinants of health, right? So we had our patients the best example is heart failure patients that we gave them all this care, and we gave them, do you remember the notebooks with the red light, yellow light, green light? And these are all the things you need to do. Then we send them on their way. And then when they were back with an exacerbation, maybe 4 weeks later, what did we say? Well, we taught them everything they needed. I don't know why they are back again. They must have been eating too much salt. We addressed that in healthcare, and we looked at, what was happening after the discharge. How do we support those patients once they're home to help them address the barriers to their self-care? We can do that same shift in nursing education. We have our students in class. In the presentation I gave recently, I gave this case study of a student who was sitting in the back of the classroom on his phone during class. He seemed distracted. And, what would we say about that student? Well, he's just not interested. Why am I going to care if he doesn't care? But in actuality, that student was a new single parent. He was working PRN shifts and facing food and housing insecurity. The shifts that became available during the class that you're teaching. First of all, creating an inclusive environment where students feel safe allows that student to come and say, I'm really sorry that I look like I'm not interested in your class, but in fact, this is what's happening. If we don't have that kind of environment, we can set the stage for students with our language messaging. You need to do this, 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 or this, or you're not going to progress. And that creates a framework where if a student is working night shift or, facing eviction, they're not going to come and talk to you about that because they don't want you to then treat them like, well, I knew they weren't going to be successful. We really want to create this environment where students feel safe to disclose their needs and then have resources, have connections for resources. And that doesn't mean we have to provide it. Actually, if we want to treat our students with respect, we don't want to marginalize them like, well, we have a food bank or we have free uniforms. Right?
Mm-hmm. Mm-hmm.
So that's another category, like understanding what our students' unmet needs are. We know Maslow's hierarchy of needs. We can't expect patients to be able to adopt self-care management strategies for disease management if they don't have food, housing, and safety. The same is true for our students with learning. We can't expect them to be able to learn and understand and apply and move to those higher levels of clinical decision making and clinical judgment if they're facing food, housing insecurity. And there are models out there. We don't have to reinvent the wheel. There are models for resourcing, and some of them are institutional. If they're not institutional systems in place for having referrals for students for things like housing or childcare or transportation, we can, at least on an individual basis, know the 211 system. When a student has a particular need and help them navigate the resources that are available in the community by, connecting them. We don't have to create the resources. We just have to think about how we can create connections.
Right. And I think of, just on a side note, as you were talking, I was thinking, the faculty orientations that we do as we bring on new faculty into our programs. And many of these individuals are coming from, the bedside, are excellent clinicians, and now they're learning the role of a nurse educator. How do you insert some of that training, if you will, and that professional development into that faculty orientation from the beginning so that it is an expectation of the role that, you create that safe learning environment. This is how you might do it, having awareness of those social determinants of learning. What are they? And as you said before, implicit bias, and some of those other pieces so that our faculty feel comfortable and our faculty have the tools to be successful and that they can have that great situational awareness when they come into the classroom and really be able to meet the needs of and individualizing their instruction and support for the students.
It's a great point. And in my perfect world, that would all be part of new faculty orientation. But as we're aware in nursing education, when we're bringing in full-time faculty, it's a heavy lift to learn the courses, learn content delivery, all the things that are important for nurse educators. We're good at teaching nursing, but all of these other things that are so important tend to get lost in the shuffle. The other challenge, as all programs are familiar, when you're bringing on adjunct faculty, you're bringing them on, and there's in higher education right now, things are not soft and flowing with money. So there's financial constraints. Bringing in people and having resources for orientation activities that include all of this, it's probably not feasible for most programs.
Mm-hmm. As critical thinking is the foundation of clinical judgment, and that it should also be the foundation of educational equity. So thinking like a nurse, it means assessing, diagnosing, intervening. So what does it look like when educators apply that same mindset to student success? Could you share a few examples of how this mindset shift can transform institutional culture?
I love this question. Thank you for asking this. We are really embedded right now, I think, in nursing education with a lot of emphasis on clinical judgment and, how do we think like a nurse and support students' development in clinical judgment, and using Tanner's model. We teach the nursing process, Tanner's model, then the clinical judgment measurement model at a higher level, with a lot of emphasis on practice readiness. And sometimes there's a dichotomy between practice readiness and NCLEX readiness, right? We see them as two separate, when in actuality, I think there's opportunity for us to incorporate them into this structure of thinking like a nurse. And as we know, critical thinking is the foundation of that. Authors have written on this topic of critical thinking, and in some ways, it's gotten lost in clinical decision making and clinical judgment, that we don't teach critical thinking. We assume the foundation is there. And you need to have that basis of critical thinking, the why. Why is this happening? To be able to apply your learning in testing, and then to move on to the next level, which is clinical decision making. We really can't assume that all students come to us with strong critical thinking skills. And in actuality, students from the underrepresented minority groups that we want to draw into nursing education and into the profession may be more likely to be missing that foundation of critical thinking development as part of their environment coming into nursing school. So that's something that I think we shouldn't overlook, that we need to look at how we can go back to teaching what is critical thinking, and even having some practice with critical thinking in foundational level courses. Help students to see. One of the things I like to do is help students see, how have you used critical thinking today to get to this class on time, right?
Mhm.
So it's not critical thinking just related to what are you learning in fundamentals and how does it apply to the lab and the clinical, but how do you use critical thinking? And then also considering, what are the characteristics of critical thinkers, right? Critical thinkers really need to be open-minded. They need to be curious. They need to explore why on their own. And not everybody has had a framework for that environmentally, depending on their family structure, their environmental structure, their academic structure. If they're more told, like, this is what you need to learn and how to learn it, and not encouraged to be inquisitive and curious, that's a foundation. And then we can apply that as well and lean into critical thinking when we're trying to understand what are the barriers for students. So if we see students not being successful, that goes to our inquiry. Why are our students struggling with this course or with this topic or in this clinical situation? And what can we do to understand? I mean, it's Tanner's model. Like, let's notice, let's assess, how can we gather information about what barriers our students are experiencing? How do we interpret the information that we gather? How do we respond? What can we do to address those barriers? Are there things in the courses? Are there things in the way that we present content that are adding to struggles that students are facing? And then when we make changes, reflecting on that. Did we listen well enough? Did we respond appropriately? Did we meet needs? We look at outcomes. What is our retention? What are NCLEX pass rates? So we have quantitative data, but when we reflect, we can also reflect on ourselves. What is our culture of inclusion? How well do we support curiosity? How do we role model a growth mindset? A growth mindset is the neuroplasticity that allows our brains to change when we think we can be successful. Our brains actually change. We harness more neurotransmitters and we learn better. So we can role model a growth mindset for our students, and we can foster and nurture a growth mindset. And we can do that in the language. Like, in my practice, I work with and coach individuals who have not been successful on NCLEX. We do not use the word fail. I use the word, you didn't pass, you weren't successful. And it's really powerful to say, look, you made it through nursing school. You can do this. And it can be transformative because we create these barriers with standardized testing. If you didn't get the exam average the first time through the course, well, you only have one more chance to succeed. You're in that pot of students who are at risk, right? And that is so counterproductive to a supportive culture for learning and supporting a growth mindset.
It can produce a lot of anxiety with that student, which then we see them start to spiral. Can I really do this? It's pretty detrimental as they try to move forward, for sure.
Oh, and we've all seen that spiral.
Yeah.
We've all
Yeah.
seen, and the same spiral happens with NCLEX. For individuals who don't pass it the first time, their chances of retest success drop
Right.
significantly because they just get stuck in that, I'm not smart enough. When I work with students, they'll come to me with language like, I've always struggled on tests, or this has always been hard for me. Then we work on, it's kind of like cognitive behavioral training, right? We work on, let's rephrase that. Let's reframe that thinking. And I even tell students, like, put little stick-it notes around. You rock. You are the best.
Positive
Change.
affirmation, right? Yeah.
Yes, it's powerful.
Before we wrap up, Cheryl, we'd love to have you share a final spark, a key takeaway for our audience. What spark do you have for us today?
Well, my spark is that, healthcare faced a really wicked problem when value-based care came to the forefront, but they fixed it. They learned how to pivot. They learned how to provide patient-centered care that improved outcomes by addressing both systemic barriers and by individualizing care. So my spark is that we can do this in nursing education if we are all brave and if we're willing to shift our focus from thinking, well, the students just aren't trying, to thinking, what can we do to support learning? And I think even if for nurse educators who are in institutions or in programs where they don't see opportunity for a culture shift, you can start as an individual and you can be that role model, that voice that promotes change, even if it's just, are you going to look at the language in your student handbook, or you can look at the language in your syllabus, in your role modeling, in how you interact with students and address student needs and support students. You can be a motivator for change that can then bubble up as a role model for other people to adopt your positive change.
Thank you so much, Cheryl, for sharing your insights and your passion today. I think this conversation reminded us that inclusive education isn't just a goal, it's really a responsibility. And by thinking like nurses, we can build systems that every student is supported, that we support their journey and spark lasting change. So thanks again, Cheryl.
Thank you. It was really an honor for me to be able to talk to you about this.
Thank you for joining the Lippincott Spark Illuminating Nursing Education podcast. Enjoy this episode, subscribe, share, and leave us a 5-star review. For more information, click on the link below to learn more about Lippincott Nursing products and services. Until next time, keep leading, learning, and making a difference in nursing education.